So let's move on to the topic. So today we'll be talking about the little bit about the anatomy development and the anatomy of the lacrimal drainage apparatus, and then discuss something about the etiopathogenesis of PANDO SALDO and how we are going to investigate a case of PANDO and SALDO. So the development starts by the 5th week of gestation. Between the maxillary process and the lateral nasal process, there is a groove which deepens and becomes a cord and gets submitted into the, it separates from the surface ectoderm, and it goes into the surrounding mesenchymal tissue. It elongates, and the cranial end, which is the future lacrimal sac, separates in, diverts into two branches, which are the future canaliculi, and they go and communicate with the lids. The lower end elongates and becomes the nasolacrimal duct. This lacrimal groove is the first step. By 5 to 10 weeks, this elongation and everything happens. And then the canalization of the lumen begins. And by apoptosis and disintegration of the cells, the lumen, the clear lumen forms. There is a communication between the canaliculi and the lids, but this does not open till the 7th month when the eyelids separate. The communication at the lower end of the canal with the nasal mucosa does not open even at birth. Only at 30% of the cases it opens at birth. The anatomy of the lacrimal drainage starts with the punctum and continues as the canaliculi, the upper and the lower canaliculi, the sac and the NLD. We all know that the punctum is present at the medial end of the upper and the lower lid. What we have to know is that there is a papilla, a prominence on which this punctum is located, and this lower punctum is 0.5 to 1 mm away or lateral to the upper punctum, so that when the lids close, the two puncta do not oppose and prevent lacrimal drainage. The second thing is the canaliculus part has the upper and the vertical part and the horizontal part. The vertical part is 2 mm and the horizontal part is around 8 mm. And the junction, there is a dilatation called the ampulla of the canaliculus. Both the upper and the lower canaliculi meet at the common canaliculus before entering into the lacrimal sac. Now the lacrimal sac, which is present at the lacrimal fossa, the medial canthal tendon is an important landmark here, which helps us to identify the sac. The part of the sac above the medial canthal tendon is called the fundus, which is around 3 to 5 mm, and the part below is the rest of the sac, around 10 millimeters. The lower part of the sac continues as the NLD into the nasolacrimal canal, into the bony canal, and then it opens into the inferior meatus. There is a small continuation of this membranous NLD before opening into the inferior meatus. Now we need to understand that the canaliculus and the punctum are lined by the stratified squamous epithelium, and the canalicular wall has more elastic fibers which help in the change in the size of this canaliculus. It can shrink or it can expand. The same way in the sac and the NLD, we have the stratified columnar epithelium. There is a change in the epithelium from squamous to columnar epithelium. It has lots of cilia, and there are lots of goblet cells and serous glands as well here. These goblet cells secrete a lot of mucus, which also helps in preventing the microorganisms from entering in a retrograde fashion from the nose. The cilia allow only one-way transport of the lacrimal drainage from superior to inferior direction, and the structure of the lacrimal sac and the NLD is described as a vascular structure, a cavernous structure with lots of vessels, namely the barrier artery and capacitance and throttle veins. So this structure is important because this helps to alter the size of the lumen. Now, what is it important for? It helps in tear reabsorption, as well as it is under autonomic control like the nasal mucosa. It alters the tear, the NLD lumen, and helps in tear reabsorption. The relationship of the medial canthal tendon to the lacrimal sac is very important. So the medial canthal tendon has a anterior limb and a posterior limb. The anterior limb has two lamella, the anterior lamella and the posterior lamella. These are attached to the anterior lacrimal crest. The anterior lamella is the pretarsal orbicularis, And the posterior lamella is the musculocutaneous fascia of the preseptal and the orbicularis, orbital part of the orbicularis. Now, we also should understand the special muscles, namely the muscle of Riolan, which is the pretarsal orbicularis that is around the punctum and the vertical part of the canaliculus. And you should also remember the Horner's muscle, a specialized part, which was initially considered as part of the pretarsal preseptal, but it is considered as a lacrimal part of the orbicularis. The Horner's muscle is the lacrimal part of the orbicularis, and it covers it is in close association with the canaliculus, the lateral 4/5 of the canaliculus, and it reflects or it moves away from the sac and inserts into the posterior lacrimal crest. Now, this picture shows the association between these muscles, the medial canthal tendon. This is a very important landmark while doing surgery, because when we cut the medial canthal tendon or reflected, the structure underneath is the lacrimal sac for us. The bony anatomy, the lacrimal fossa, the lacrimal sac is present in the lacrimal fossa, which is bounded by the anterior and the posterior lacrimal crests. The anterior lacrimal crest is formed by the frontal process of the maxilla, the posterior lacrimal crest by the lacrimal bone. And this lacrimal bone is where we have the maxillolacrimal suture here. This lacrimal bone is where we open when we do a DCR to create the bony ostium. And this is a sutura nota here. This is not an actual suture line, but it is a vessel groove that is formed by the impression of the branch of the infraorbital artery. And we have the bony NLD. The bony NLD is formed temporally by the maxillary bone and medially in the superior part by the lacrimal bone and inferiorly by the inferior turbinate. Vascular supply of this area, the lacrimal sac area, is by the facial artery, which continues as the angular artery and drained by the angular vein. And it is a very important point to note that this vascular supply is present around 5 to 8 mm from the medial canthus. So when we make surgical incisions, we have to mind this. The nerve supply of the lacrimal area, the drainage area, is mainly by the infratrochlear branch. Okay, so when we block for DCR, this is the area that we need to block. So now we know the anatomy. How does the tear drain from the eye into the inferior turbinate? So what is the mechanism that helps? So we have the specialized lacrimal pump mechanism, wherein when the there is a relationship between the caruncle, the lacrimal lake, and the punctum. They should be in close association. Okay, so when the eyes are open, the punctum and the canaliculi are relaxed because the orbicularis is relaxed, and the tears enter by capillary action into the canaliculi and enter the sac. Now, when the eyes, when the person blinks, when the orbicularis contracts, the Horner's muscle contracts, it pulls and closes the canalicularis, and it presses on the, or it moves towards the attachment. It shortens the canalicularis, thereby pumping the tear into the lacrimal sac. And the preseptal orbicularis compresses the lacrimal sac, pushing the tears into the NLD. Now, when the eye opens, when the orbicularis relaxes, the negative pressure that is created by the emptying of the sac and the opening up of the canalicularis creates a suction pressure as when the tear enters into the canalicular system. Okay, so is this the only way? No, there are some explanations that are given when the tears get drained even when the eyes are open. Okay, that is by the pressure gradient between the canaliculus and the sac. There is a lower sac pressure, intra-sac pressure compared to canalicular pressure, and that has been described by some Japanese researchers. That is called the Kriebial flow. Now, once the tear is drained, what happens to it? It is usually reabsorbed. Most of it is reabsorbed, and the cilia in the sac and the NLD help in reabsorption by increasing the surface area, and the autonomic overactivity, which causes the engorgement, which causes the sympathetic response, causes draining of the vessels, the cavernous structure. So it helps in drainage. But when there is a parasympathetic overactivity, there is engorgement of these vessels and the lumen narrows. So in such a case, the reabsorption is more. Now, that is how the tear gets reabsorbed. Now, what is epiphora? We all know it is the most common symptom. Epiphora is watering. Patient comes to you with epiphora. We don't know whether it is primarily because of a disruption between the tear production or tear reabsorption. Now, what is the goal of epiphora evaluation? We need to know whether it is a true epiphora, which is because of obstruction, or because of hypersecretion or pseudo-epiphora. The next thing that we need to identify is whether there is an anatomical obstruction that is causing the epiphora, or whether it is a functional or a non-obstructive cause. The next thing is, if it is anatomical, where is the level of block? Is it in the upper system, that is the punctum and canaliculus, or is it in the lower system, that is the sac and the NLD? So how do we do functional assessment? Functional assessment for the pump mechanism, especially the orbicularis muscle, we do the distraction test, snap test, and the pinch test. That will easily tell us about the orbicularis pump. Then we'll move on to the acquired obstructions, since congenital will be dealt by subsequent speakers. So the primary acquired nasolacrimal obstruction is any lacrimal disease that is caused by inflammation or fibrosis without any cause, right? So whenever there is an unknown cause of inflammation, there is stasis because of mucosal edema and vascular congestion. In case of secondary, Bartley et al. Proposed an etiologic classification based on the published causes, and they classified them as infectious, inflammatory, neoplastic, traumatic, and mechanical disorders. This traumatic is most common following the naso-orbito-ethmoidal fractures, and inflammatory may be because of endogenous like vaginas and all, which involve the nose, the paranasal sinuses, or exogenous by use of long-term topical medications or radiation therapy, or because of chemotherapeutic agents. Neoplastic can be a primary of the sac area, or it can be a secondary spread from the lids or from the nose, paranasal sinuses, and the nasopharynx, or it is also reported from distant metastasis, primary being breast and prostate. So how do we start evaluation of a case of epiphora? We start with the history taking, which helps us to give a clue as to whether it is acquired or not, right? Shortly after birth means it is definitely a congenital case. And we also have to ask history about whether it is a pseudo-epiphora. So ask for other associated symptoms, whether it is bilateral. Usually bilateral means allergic conjunctivitis or something. If it is a unilateral, it could be because of a trauma or previous treatment, which has, so you look for all that. And then you also see if it is intermittent type or a continuous type. A continuous type usually is because of a complete NLD obstruction. An intermittent type which exacerbates with the URI and all can be a partial NLD obstruction. Also ask for history of any previous intervention, if any. The local examination of case starts with inspection. So we see, we do a thorough inspection of the face, the nose, the paranasal sinuses area, the periorbital area. Most important, this is to rule out the other causes. Okay, this is not, this is to rule out the pseudo-epiphora causes, and also look for the position of the lids. The lid malpositions which prevent the opposition of the punctum can be a cause for epiphora. Also, there is this centurion syndrome, wherein there is an anterior insertion of the medial canthal tendon, which pulls the punctum away from the surface of the globe. Look for gross nasal deformity or facial asymmetry, and history of sac swellings, whether there is any swelling in the sac area, previous history is there, then there may be some scarring, there may be a fistula. Okay, so look for all these. Palpation of the sac, we all know we do the Roplast test very commonly. So one thing that we should remember is we should apply the pressure on the sac in a backward and upward direction. Okay, this is very important. And once the pressure is applied, if there is any regurgitation, normally it is not present. If it is present, you should look for the type of regurgitated material and whether it is coming from the same or opposite punctum. So if we get a mucoid mucopurulent regurgitation, that means it's a clear-cut case of NLD, and we won't need any further investigation to confirm this. Then if it is associated with blood-tinged fluid, if the regurgitation has a blood tinge, you have to rule out sac tumors. If there is no regurgitation, but still there is a distended sac, suspect encysted mucocele. If there is no regurgitation, but the sac empties on pressure, there could be some internal fistula or a atonic sac. A slit lamp examination to rule out the pseudoepiphora causes, and also to look for the upper system block, namely the punctum, and the canaliculus if there is any evidence of canaliculitis or a punctal stenosis, and also look for the ocular surface. Examining the drainage pathway can be excretory or secretory tests. The secretory tests basically are the Schirmer's and Tibet, which evaluate the tear secretion. The excretory tests are the ones that are going to check the drainage pathway, and we can do a anatomical assessment as well as a functional. How is the drainage? So anatomical assessment is done by the lacrimal irrigation, probing, and the DCG. So lacrimal irrigation, all these are done. I hope you all are aware of the procedure. So the important thing that you should remember is, after dilating the punctum dilator, this is all done under topical anesthesia, dilate the punctum and do not forget to retract the lid or pull the lid laterally. This will only straighten the canaliculus, the vertical portion of the canaliculus. So straighten the canaliculus and then insert the lacrimal cannula, a 24 or 25G cannula, which is attached to a syringe filled with saline, and irrigate. So what are the possible outcome? Normal patent drainage, the fluid will be felt in the throat. You can even observe the swallowing movement if the patient is not able to say clearly, and you can get a regurgitation. If the regurgitation comes from the same punctum, or you have to see if the regurgitation comes from the opposite punctum. If the regurgitation, clear fluid regurgitation comes from the same punctum, immediately it is a canalicular block. If the regurgitation comes from the upper punctum, it could be a common canalicular block. If you get a mucoid or a mucopurulent regurgitation, clearly it is from the sac. And if it comes from the same punctum, it could be an NLD obstruction with an upper canalicular block. If it comes from the opposite punctum, a mucoid or a mucopurulent regurgitation from the opposite punctum is a confirmation of your lower sac or an NLD block. In case of an atonic sac, what happens? Because we are pushing the fluid, it is not a physiological test. We are under pressure, we are pushing the fluid into the drainage system. So when the sac dilates and it is patent as well, the sac dilates, it is patent as well, and there is a residual stasis. In case of a atonic sac, the sac is not able to pump, but the system is patent, right? And in case of a partial regurgitation, the patient will feel the fluid and you will see the regurgitation as well. Probing again is done with the after dilating the punctum and introducing the Bowman's probe. Here again, you have to make sure that you retract the lid laterally so that the canaliculus is straightened. And you can get two possible interpretations here. There is a hard stop and a soft stop. The hard stop shows that the probe is hitting the bone. It has crossed the canaliculus and it is into the sac, hitting the bone. The soft stop is when there is a canalicular block or a common canalicular block, or sometimes when the procedure is done wrongly, the lid is not retracted, the canaliculus can kink, and that can cause a false positive soft stop. The fluorescein dye disappearance test is a functional assessment. We instill the fluorescein dye into the conjunctiva and wait for 5 minutes and see whether how much of the residual fluorescein is there in the conjunctival sac. And this is followed by the Jones test, which is not done routinely nowadays. What are the indications of imaging? With clinical and these tests, it is almost confirmatory for NLD occlusion. So when do we do these imaging techniques? Especially following post-traumatic cases, or when we suspect tumors, or there are some anatomical variations and there are some uncertainty of the cause, we go for the imaging. We have the digital subtraction dacrocystography and the CT and MR dacrocystography. So in dacrocystography, we usually inject a dye, a radio opaque dye, and then take a serial image and observe the drainage pathway. And this gives a clue about the anatomical obstruction. The radioisotope study, namely the scintigraphy, gives it helps to assess the physiological pump mechanism. So the digital subtraction dacrocystography is useful in cases of obstructions and diverticulae, and also to detect dacrylithiasis. So the first picture is the conventional radiology, which is not done. This is the digital subtraction picture. You can see after subtracting the noises, you can see the clear-cut anatomy of the system, which is highlighted by the contrast material showing a block in the NLD. Ultrasonography can also be done wherein the lacrimal sac appears as an echo-free structure. Though it can be done as an OPD procedure, it is not of much use as it lacks anatomical details. CT-DCG can be done by injecting the radiopaque dye either as a drop or by cannulating the canaliculus. And it is very useful for traumatic obstructions wherein the bony structures are delineated in an excellent manner, and also in case of tumors involving the sac, this is very useful. So here you can see the dye that is highlighting the canaliculus and the sac. And in the second picture, you can see the nasolacrimal duct, which is draining into the inferior meatus. So this was another CT-DCG picture where you can see the right side is patent, and here the left side, there is accumulation of dye within the sac showing the block beyond this level. This was a patient who had undergone, who had a nasoethmoidal fracture, midface fracture, and undergone some repair. And post that, the patient had epiphora on the left side, and you can see the dye that is seen in the sac and into the NLD in the right side, but the same is not seen in the left side. You can see again, the left side, if you observe carefully, the dye is not seen beyond this. So there is some obstruction. So the anatomical details are very well delineated by the contrast CT. DCG, of course, the advantage is that it is a superior soft tissue delineation, and it can even differentiate the lacrimal signals from the surrounding structures. But because of the longer acquisition time and bony details, this is not of much use. Scintigraphy is by using the radioisotope technetium-99. So this is introduced into the conjunctival sac, and the patient is asked to blink, and the natural path of the function of the physiology of the lacrimal drainage pathway is assessed over 30 minutes. And the end point would be the identification of this radionuclide dye in the nasal cavity. You can see clearly here, the right side, the dye has started collected in the sac, and then it is coming down into the NLD and the inferior meatus, while in the left side, it is not so. However, the only thing is in scintigraphy, we cannot differentiate whether it is a functional block or an anatomical obstruction. No lacrimal assessment is complete without a nasal endoscopic examination, which will be dealt subsequently. So the nasal endoscopy is very important to identify any concurrent nasal pathology or variations in the anatomy, which may need to be treated even before we tackle the epiphora. And also very, very important in cases of evaluation of a post-DCR case, a failed DCR, or how is the ostium and all. So nasal endoscopy is very useful. For completion's sake, I have mentioned this for the residents. Dacryoendoscopy is a microendoscopic technique, wherein a microendoscope is introduced through the canalicular system, and right from the punctum to the lower end of the NLD, it can be visualized either in an anterograde or a retrograde manner. Of course, in case of SALDO, the secondary causes, do not forget about the lab studies. And for vaginals, we can do the ANCA. So basically, the lacrimal drainage is a complex interaction between the anatomy, the physiology, the pump mechanism, and the position of the lid. A good understanding of this will help us a long way in management of epiphora. Thank you for your patient listening.